these groups get together, they can start to think about in a coordinated fashion to address issues of training and education and lifelong learning for physicians.
Dr. Lomas.
Yeah, as you know, Todd, the disruption presented to medical education by the pandemic extends well beyond what any single institution can address on their own, whether that's a medical school or residency program or a healthcare delivery institution. And so the coalition is really the important group to bring together the perspectives of all the right stakeholders to look at this from more of a systems lens. And a lot of the work is anchored in some guiding principles of keeping patient safety and the safety of learners at the forefront, making sure that all our learners can meet core educational needs, and to really recognize and acknowledge that there is difference across the country in the impact of this, and how can we mitigate this as much as possible given the realities of our situation.
You each participated in different work groups within the coalition. Can you summarize what issues your work group addressed, as well as the resulting recommendations? Dr. Andrews, why don't you start?
Sure, thanks, Todd. I was part of a work group that aimed to address the uncertainty around the transition from medical school to residency that's coming up this summer. As people are probably aware, somewhere in the neighborhood of 30,000 medical school graduates will be transitioning to residency positions, many of them in cities other than the cities in which they attended medical school. And that raises a host of concerns about exposure to infection, about the impacts of health screening and quarantine on their ability to start working in a new clinical environment, and frankly on practical matters like their ability to find housing and participate in orientation activities. And so my work group was charged with attempting to the best of our abilities to provide some guidance around those issues.
I was serving on two different work groups. One focused on the volunteer activities that students started to engage in. As we've discussed before, Todd, as you know, as soon as students were removed from the clinical environment, they jumped in wanting to serve with a variety of volunteer activities. Since that time, some of those activities have been taken under the wing of the schools, and sometimes even leading to elective credit. And looking forward, it may even be appropriate for some of those things to be included in mandatory coursework. So that particular team looked at the swath of those activities and made sure that people were fully aware of the potential risks associated with them and that the right precautions and protections were put in place. The issues of credit are very appropriate because a lot of these activities do contribute to the development of physicians in the way we would like to see them grow. The other group that I was part of arguably has had the most attention on its recommendations, and that's a group that looked at the residency selection process for the rising senior class, the class of 2021. Historically, that process has involved a lot of travel between away rotations at other institutions and the entire interview season. So we knew we had to make some changes, and it's important that those changes be consistent throughout the whole cycle, even though you might have some months in which that travel is okay, or some regions in which it's okay. If the playing field's not even for everybody throughout the cycle, then it makes, as you could understand, the applicants quite nervous. So that group had three main recommendations that they put out to really pretty much ban away rotations. To be more specific, really curtailing the audition rotation. That's when a student goes to a specific program hoping to strut their stuff and getting to know that single program a bit better. There is a carve out because there are some a need for away rotations to meet core educational requirements. So there's a little bit of protection there. But for the most part, really trying to discourage students to move into a different system right now. That's not the best for anyone. And then for the interview season, really recommending that everything be done virtually with no in-person interviews across the board. And then finally, because of all of this, shifting the application deadline by just a few weeks. That's enough to help schools and students adjust the administrative reporting. As you know, because of the disruption of COVID, coursework is different, the grades are different. So the dean's letter, the MSPE that the schools produce needs to be adjusted accordingly. And that window gives a little bit more time to make that as replete as possible. But students need to know that it's not enough time to rebuild some of the experiences that they would have hoped to have had, whether that is various clinical rotations or whether it be global health experiences or research experiences. But it's important that the students are aware that the programs fully recognize that and they're not expecting as many of those activities in the application this coming year.
Dr. McDade, your work group?
So my work group focused on the maintenance of quality and safety standards amid the crisis. And one of the things that we're most concerned about is that various states and governors have permitted individuals who are outside the normal licensing practice for the state to enter into practice in that state in the flood of cases that were coming in. Some states also allowed people who graduated from medical school prematurely, that is before graduation period, and allowed some international medical graduates potentially to come in and become practicing physicians for a temporary basis in those states. So our group really focused on, first of all, ensuring that the attestations of the individual were consistent with the licensure information that was available for those individuals, so that you knew whether they were board certified or not, you knew whether they had licenses elsewhere or not, and you could figure out whether or not this person was really consistent with the picture they were showing. The other thing we wanted to make sure is that the provision of care was going to be adequate for those individuals who were in practice. And so that if an individual had not been in a practice environment that you were now going to ask them to serve in, that there was adequate supervision of that individual and instruction as to how to regain those sorts of skills and accelerate back up to where they could actually handle patient care safely. One of the things that goes along with that is the adequate provision of PPE, personal protective equipment, to ensure the safety of those individuals coming into those environments. There's also the idea that physicians in general have a duty to serve even during these pandemic situations. And that's part of the AMA ethical principles, but I think is really adopted for physicians across the continuum. And the final thing is we wanted to make sure that safety standards were adhered to as part of what we were doing by bringing in people from the outside, whether it's retired physicians or come back into licensure, or whether it's new physicians who just left graduate medical education or just left medical school to help out in the crisis.
Dr. McDade, we know these disruptions will likely have a rippling effect on many areas. How do you see them impacting diversity specifically?
Well, as you well know, the initial problems that we saw with COVID-19 were very much concentrated in areas that had a high concentration of underrepresented minority individuals. And in fact, in Chicago, where I am and where you are now, of the first 100 cases of COVID, 70 of them were of African Americans. 70% of cases were African American, 50% of death were African American. We saw the same sort of pattern in Louisiana in its initial outbreak. And the thought was that because we have people who work in the gig economy, that is, they are part of the essential group that may not necessarily be in healthcare, they had to keep working. One of the things that you are really seeing is that the social determinants of health underlie what we see in general for health and exacerbate in those situations of crises like COVID. And so it's really pulled off the scab on a bad wound that our country's had in the disparate healthcare between minority populations and the majority population. Our hope is that we can use this as a means to think about prevention and planning for future pandemic situations, and to really work on equity in the healthcare system in general, so that we can eliminate the risk that we put certain communities at.
Well, thank you, Dr. McDade, Dr. Lomas, and Dr. Andrews for being here today and for sharing your perspectives. That's it for today's COVID-19 update. We'll be back tomorrow with another update. In the meantime, for resources on COVID-19, visit the AMA COVID-19 Resource Center at ama-assn.org/COVID-19. Thanks for being with us here today, and take care.